Bismillahirrahmanirrahim. Quote of the day: the universe responds to specificity. Assalamu alaikum. Today, the topic of my presentation is assessment of validity and reliability of diagnostic and screening tests under kind supervision of Professor Dr. Saira Afzal. Learning outline of my presentation is about validity, types of validity, use of dichotomous test, use of multiple tests, disease prevalence and positive predictive value, type of different variation, KAPPA statistics. In the end of this presentation, my participants would be able to describe about validity, screening test, KAPPA statistics, and recent advances. Validity. Ability to distinguish between who has the disease and who does not. There are different types of validity and we discuss one by one. First one is construct validity. It refers to the extent to which operationalization of a construct, for example, practical test when developed from a theory. And the next one is content validity. It is a non-statistical type of validity that involves the systematic examination of the test content to determine whether it covers a representative sample of the behavior domain to be measured. Next is the face validity. It is an estimate of whether a test appears to measure a certain criteria. It does not guarantee that the test actually measures phenomena in that domain. Measures may be high validity, but when the test does not appear to be measuring, then it maybe has a low face validity. Next one is concurrent validity. It refers to the degree to which the operationalization correlates with other measures of the same construct that are measured at the same time. And in the predictive validity, they describe refers to the degree to which the operationalization can predict or correlate with other measures of the same construct that are measured at same time in the future. And the last two are internal validity and external validity. Internal validity is an inductive estimate of the degree to which conclusions about causal relationship can be made, for example, cause and effect, based on the measured use, the research setting, and the whole research design. And in the external validity, it is mostly concerned the extent to which the results of the study can be held to be true for other cases, for example, to different people, places, or time. In other words, it is about whether finding can be validly journalized. Validity has two components, which are known as sensitivity and specificity. The sensitivity of the test is defined as the ability of the test to identify correctly those who have the disease. And the specificity of the test is defined as the ability of the test to identify correctly those who do not have the disease. This is the 2x2 table and how we show the sensitivity. So sensitivity is equal to true positive and divided by true positive or false negative result. In 2x2 table, there are four boxes are made. Disease is present. It may be true positive or false negative. And when disease is absent, then the result may be true negative or false positive. This is how we show the sensitivity of any screening test. And this is the formula of specificity. And in specificity, our main concern is true negative, those who does not have disease. And it is divided by true negative plus false positive. Now we apply different test with a dichotomous result. Dichotomous mean the test having only two results. One result is positive and one result is negative. And sensitivity and specificity describe about the patient who have disease, and specificity describe about who have not the disease. This is the 2 by 2 table and example. Assume a population of 1,000 people, of whom 100 have disease and 900 do not have the disease. A screening test is used to identify the 100 people who have the disease. We draw 2 into 2 table, and 80 is right up in the true positive and 800 is right up in the true negative. And when we calculate the sensitivity, we divided 80 over 100, which is the total of true positive and false negative. So we can calculate the sensitivity by this formula, and the sensitivity is 80%. And when we calculate the specificity, we take this figure 800, which show the true negative result, and this 100 shows the false positive, and the total is 900. So we divided 800 over 900 and the answer is 89%. The sensitivity of the test, which is defined as the proportion of a disease people who were correctly identified as positive. So 80 divided by 100, 80% is the sensitivity. The specificity of the test, which is defined as the proportion of non-diseased people who are correctly identified as negative by the test. So therefore 800 divided by 900, so the specificity is 89% according to this example. Test of a continuous variable. In the dichotomous test, we can only predict the result in the negative or a positive aspect. But in a continuous variable, what we did, test for a continuous variable like a blood pressure and a blood glucose level, for which there is no definitive positive or negative result. A decision must therefore be made in establishing a cutoff level, above which a test result is considered positive and below which a result is considered negative. This is the example of the diabetic patient. In the blue box, there is a patient who have diabetes, and in the red, if we suppose this is the level of blood sugar, and if we take the cutoff level of the blood sugar very high, then these are the people who are diabetic, which are 5 in number, and these are the people who are true negative, which are not in the diabetic status, and these are non-diabetic. So this is the number of 18. So suppose a relatively high cutoff level if chosen, so the sensitivity of the test using this cutoff value will be the 25%. 5 divided by 20, result is 25%. And the specificity is when 18 is divided by 20, the result is 90%. So if we take over a value very high, the sensitivity may be 25 and specificity is 90%. But when we take over value, cutoff value very low, then a large proportion of non-diabetic is identified as non-diabetic. So the result is the majority of the people are labeled as true positive. In this figure, when high cutoff value, the figure is 5, and when there is a low cutoff value is taken, then true positive result is 17, and only 6 people are in the true negative result. So over sensitivity and specificity is, now the sensitivity is 85% and the specificity is 30%. So this is how we interpret that if the cutoff level is high, the sensitivity is very low. And if we take the cutoff level is low, then the sensitivity is high. Then we use a multiple test. In sequential or two-stage screening, a less expensive, less invasive, or less uncomfortable test is generally performed first, and those who screen positive are recalled for further testing with a more expensive, more invasive, or more uncomfortable test, which may have greater sensitivity and specificity, bringing back for further testing only those who screen positive will reduce the problem of false positive. In sequential two-stage testing, first we identify the diabetics, and when the figure of diabetic is come like true positive result, then all these people are taking into the second test, which is a glucose tolerance test. And in this test, when you can see when we applied both tests, first the sensitivity, when we apply the blood sugar level, so the sensitivity is 70% and specificity is 80%. But when we take all these positive result and then we perform a glucose tolerance test, so over sensitivity is also increased and over specificity is also increased. So this is the purpose of sequential testing or two-stage screening. Now comes the predictive value test. There are two types of predictive value test: positive predictive value and negative predictive value. In a positive predictive value, we take only positive results like true positive or false positive in our formula, and we calculate the positive predictive value over here. And in the negative predictive value, only negative results are taken like false negative or true negative. And when we sum up, then we calculate the negative predictive value over here. Now we discuss the relationship of disease prevalence to a positive predictive value. This is the example in which the disease prevalence first is given, the disease prevalence is 1%, and then the disease prevalence is 5%. And you can see that 10,000 is the total percentage who are 10,000 is the total population, and the sensitivity is 99% and specificity is a given, which is 95%. So from the 10,000, 100 people are those who are sensitive, like 99% is a sensitivity, so we take 100, and from these 100, 99 having the disease, these are true positive, and one is false negative. And from 9,900 there is the remaining figure, and from this the true negative is 9,405. This is the 1% of this 9,900, and 495 are false positive. When we sum up this true positive, like positive predictive value, the sum is 595, and when we sum these false result, the result is 9,406. And for the find out the positive predictive value, we divide the 99, this is the true positive, divided with the total 595, and the result is 17%. And now if the population remain the same, 10,000, but the disease prevalence is 5%. So the 5% mean from 10,000, the 500 people are sensitive, which show the disease. From this 495 having the positive and 5 are false negative. And from this 9,500 remaining, the 5% shows the 9,025, which is the specificity, which we take 95% and 475. And we find out when the positive predictive value, we sum up these, and this is the total is 970, and we divide 495, which is true positive, with this 970, and the result is 51%. So in this relationship, they show that when we use the higher prevalence in the screened population, this leads to a marked increase in the positive predictive value using the same test, like same population, same test, everything is same, but only the disease prevalence is changed from 1% to 5%. Positive predictive value is also changed from 15% to 51%. In this slide, we show the relationship of specificity to a positive predictive value. In this, we can change the specificity from 70% to 95%, and the positive predictive value changed from 27% to 69%. The population is same, 10,000, and the sensitivity is taken is 100%. So we have 1,000 people are true positive and the remaining 9,000. And from this 9,000, if we take the specificity 70%, then the percentage of true negative people are 6,300. And the total of positive predictive value is 3,700. And when we divide 1,000 over 3,700, the result is 27%. And when we use the specificity 95%, the true positive people are 1,000, but this figures are changed from 9,000. When we use 95% specificity, the ratio of true negative people are changed, which are now 8,550, and the false positive are only 450. And when we find out the predictive value, the sum up is positive result is 1450, and we divide over true positive over this value 1,000, 1450, and this is the 69%. So even with 100% sensitivity, a change in specificity from 70% to 90% has a dramatic effect on the positive predictive value. So this is the relationship of specificity or a disease prevalence to a positive predictive value. Now there are different type of variation which are coming in when we read different tests or different result. So the variations are intra-subject variation, intra-observer variation, inter-observer variation. In intra-subject variation, is within the individual subject. For example, if we calculate the blood pressure of a patient in a different time interval, we can find out the different readings at a different time. So these are the variation in a same person. Intra-observer variation. This show the variation in the reading of test result by the same reader. For example, between a radiologist who read the same group of X-ray at two different times may read one or more of the X-ray different the second time. And in inter-observer variation is the variation between those reading the test result, in which maybe the two examiner will give the different result of the same test. So this is inter-observer variation. Now comes the KAPPA statistic. Percent agreement between two observers is often of value in assessing the quality of their observation. The extent to which two observers, such as two physicians, two nurses, for example, agree with each other is often an important index of the quality of the healthcare being provided. The percent agreement between two observers does not entirely depend on the quality of their training and practices. The extent for their agreement is also significantly influenced by the fact that even if two observers use completely different criteria to identify subject as positive or negative, we would expect the observer to agree about the observation made, at least in some of the participants, solely as a function of chance. This is the formula which are using for a KAPPA statistics. Percent agreement which is observed minus by percent agreement expected by chance alone divided by 100% minus percent agreement expected by chance alone. This is the example in which a pathologist A and a pathologist B read the slide of grade 2 carcinoma and grade 3 carcinoma, and they give the results. Like percent agreement observed. Percent agreement observed, the person who read the grade true slide, which is the result of true positive, and the grade 3, which is the true negative, then we plus this 41 and 27 and divided by the total number of slide. So the percent agreement observed between two observers. One observer read this quantity and one observer read this quantity. So we can sum up these results, and the percentage is 90.7%. And this result is the percent agreement expected by chance alone. If these slides are only read by 1%, then this is the percentage which is came up. For total is the 45 number of slide, and from this 45, if we take the 60% of this 45, then this percentage is come, this figure is come 26.5. And if we take the 40% of this total 30, then this figure is come 12.5 percent agreement expected by chance alone. And when we sum up this result, the answer is 51.7%. So now we take these two figures, 90.7% and 51.7%, which is used in the formula. Percent agreement which is observed 90.7, percent agreement expected by chance alone, which is 51.7%, minus in these two figures, so the result is 39%. And when 100 is minus from 51.7%, the answer is 48.3%, and the result is 0.81. And now how we interpret this 0.81? Landis and Gosford suggested that a kappa greater than 0.75 represent excellent agreement between the observer. But a kappa is below 0.40, it represents a poor agreement between the observer. And if the kappa is between 0.40 to 0.75, it represents the intermediate to good agreement between the observer. Now comes the relationship between reliability and a validity. The test results obtained are shown by the curve. The curve is narrow, indicating that the results are quite reliable, repeatable. Unfortunately, however, they cluster far from the true value, so they are not valid. For example, this is the true value, but our results are here and the graph is drawn. So these results are valid but not reliable. But if our curve is towards the true value, then our result is reliable. And if our graph is this type, then the result is both valid plus reliable. Now it's time for recent updates. This is one of the article in which breast cancer incidence using administrative data and its correction with sensitivity and specificity. The sensitivity and specificity for algorithm 1 and 2 were 69% and 99.89% respectively. In contrast to specificity, the sensitivity for both algorithm were lower for women younger than 40 years of age and older than 65 years. Case reported by cancer registries were closer to case identified with algorithm. So the conclusion of this study is, if we obtain a reliable estimate of breast cancer incidence in the general population, the sensitivity and specificity which reflect medical and coding practices variation are very much necessary. So this is the practical implementation of sensitivity and specificity. Now it's time for the MCQs. XYZ test is performed and the sensitivity of test is 96% for a disease. According to this result, the remaining 4% show the rate of For example, if we draw 2 into 2 table, then the remaining 4% show the rate of true positive, true negative, false positive, false negative, or a positive predictive value.
B.
No, it's D, false negative. When we calculate the sensitivity, the upper figure is true positive and the lower one is false negative. So the remaining 96% are those who are true positive and 4% are those who false negative. A new study to diagnose prostate cancer is being evaluated. The sensitivity of test is 70% and specificity is 90%. In the study, there are 100 patients who truly have UTI and 200 who truly do not. How many false negative are in the study? 20, 25, 30, 70, 120.
Beta.
C, 30, because the sensitivity of test is 70%. So from 100 patients, if 70% have true positive, then the false negative result is 30. The scenario is same, but this time we find out the specificity. A new study to diagnose prostate cancer is being evaluated. The sensitivity of test is 700 and specificity is 90%. There are 100 patients who truly have UTI and 200 who truly do not. How many false positive are in the study? 20, 25, 30, 70, 120. 200 are the patient who truly do not disease. It means 200 are the true negative. And the specificity is 90%. Its answer is A, 20. 180 from 200, if the specificity is 90%, it means 180 have the true negative result and 20 have the false positive. A screening test is used in the same way in two similar populations, but the proportion of false positive result among those who test positive in population A is lower than among those who test positive in population B. What is the likely explanation for this finding? It is impossible to determine what caused the difference. The specificity of the test is lower in population A. The prevalence of the disease is lower in population A. The prevalence of disease is higher in population A. The specificity of the test is higher in population A.
E.
D is the correct answer. The prevalence of disease is higher in population A. Two pathologists read the slide and the value of kappa statistic calculated is below 0.45. This value of kappa represents what level of agreement? Excellent, intermediate, intermediate to good, poor, very poor.
D.
D, poor, because the kappa stats show below 0.45. BP monitoring was done on 62 years old female for 24 hours by a trained observer using standard BP operators. The reading of BP such as these are the following readings. This variation of BP would be labeled as intersubject, interobserver, intra-observer, instrumental or random variation. This is the variation of result in the same individual, like a human body. So the answer is A, intersubject variation. Same screening test was applied on two population A and B. The positive predictive value of test as calculated in two population as follows: A 17% and B 51%. So the positive predictive value show the important relation with incidence, prevalence, survival rate, life expectancy, or a morbidity.
B.
B is the right answer. Prevalence. The probability that a patient with positive result has in fact got disease being screened is known as positive predictive value, negative predictive value, sensitivity, specificity, or accuracy.
C.
No, it's positive predictive value, A. A screening test has been advised to differentiate between all those who have suffering from swine flu or not. On account of these characteristics, the test should be called sensitivity, specificity, valid, reliable, or accurate. A screening test which differentiate all those who have suffering from swine flu or not. So the test is valid. C is the right answer. A physical examination and an audiometric test were given to 500 persons with a suspected hearing problem, of whom 300 were actually found to have them. The result of the examination were as follows. Cover with the physical examination, the audiometric test is equally sensitive or specific, less sensitive, less specific, less sensitive and more specific, more sensitive and less specific, more sensitive and more specific. These are the result of physical examination, and this is the result of audiometric test. This is the sensitive true positive 240, and when we use audiometric, the true positive result is 270, and this is the true negative, D. The result is more sensitive and less specific if we compare the physical examination and audiometric test, because with the physical examination we identify true positive 240, and when we use audiometric, so we identify true positive 270. So the audiometric is more sensitive and less specific. This is the key of my MCQ, and thank you.
Thank you very much, Dr. Naila. Very nice presentation, especially about sensitivity, specificity, and how the accuracy is being calculated. The KAPPA value is very important because we know that both the observed accuracy and expected accuracy, that has to be put in the formula in order to calculate the KAPPA statistics. And I am very much sure that today the students have a very clear concept how the KAPPA statistics are being calculated, and they are applied in our normal routine practice, especially when there are different tests that are being used and where there are the issues with accuracy. The second important thing that has been presented was your MCQs, especially your MCQ number 1. It is one of a very key concept that once if the sensitivity is 96%, then the 4% are the false negative. And the most of the students can't give the correct answer. However, I think that this is the key concept and very important concept. And if there is any gap in the knowledge about this concept, it must be rehearsed, revised, and reviewed. Thank you very much, everyone. Allah Hafiz.
Good Hafiz, ma'am.